introduction, and thank you for inviting me to present a case. So, sharing our local experience. So, good evening, ladies and gentlemen. In next 10 to 15 minutes, I will take you our real world experience case, how we use guideline, how we make a diagnosis, and how we go smart sequence of therapy. As David has mentioned, there are so many therapies are there. So this is how we'll go. So first is eye opener, which guideline we use actually in all hematology and oncology. And everybody agree that we have these 4 guidelines, but what we use for ITP, we use ASH guideline. So how they go by panel information, then clinical questions, then evidence-based, they make some recommendation, which they have met, and we'll use those guidelines in my case. So first thing is to make an accurate diagnosis. So I will go through this case. This is my real case, 43-year-old male. It was about 8 years ago when he was referred to us from one physician actually, who was incidentally found with the CBC, with the platelet count is 50,000. Otherwise, he was asymptomatic and he has no any concerns of bleeding. And there was no additional finding on the exams. And he has no any past medical history, no medication. So he was referred because of 50,000 platelets. So the question is how to make a diagnosis. So what is the key to make a diagnosis? There are options. We can go imaging, we can go invasive procedure, bone marrow, or simple test, or some blood test. The key is that to check examine the peripheral blood film. Why? The important thing is first you have to see, to smear, to rule out it is not pseudothrombocytopenia. As with the ETT bottle, you always find some clumping, and that is not picked by the electronic particle counter. So you can use citrate bottle. This is one thing. And second thing, if you see in the ITP patient, you will find large platelets. So make a diagnosis by simple test of smear. And as per ASH guideline, you can rule out any infective immune phenomena by these panel of the test. So this is, a guideline which they mentioned for all patients. You have to go history, physical, peripheral film, and you can check, immune and infective process. So in this patient, actually, we have gone through. So we found in peripheral film that film shows no platelets clumping, and no other morphological abnormalities was seen. So this was typical isolated platelets with the large platelets. So, and all the tests, immune and infective tests were also unremarkable. So what was the diagnosis? Diagnosis was the ITP. Now we have diagnosis. So second thing is what to initiate with this patient. Should we treat the patient or we refer back to the physician? So as at this point, what is the next to best option of the treatment? To start the prednisolone, to discharge the patient back to the physician with the thankful for referral, or you will keep the patient with the monitoring with you, or you use dexamethasone. So I actually discharge the patient back to primary physician for annual lab workup if anything happened, and I just label ITP, then patient can to refer back to us. So this was the first step. Now, this is about ASH guideline. Why? You have seen that ASH guideline saying it is against to use steroids if the platelet count is more than 30. So best thing is observation. So this is good practice statement, which we use in this patient. Now, after 1 year, same guy who came in the ER with the history of blood blisters in his mouth and also in arms and legs. And further history revealed that he feels currently more fatigue than as usual. And examination, we found he has petechiae and ecchymosis. And his CBC revealed platelet count is 15 and hemoglobin is also 10. Now, question is, How should you manage his severe ITP with bleeding at multiple sites? So you have option. Will you do same thing which we did before, observation, or use prednisolone, or you will admit and send the patient home, or hospitalize the patient, or you use TPO agonist as a first go. So it was 10 years ago, as I mentioned about. So I admit the patient and start the treatment with the steroid. Why admission? We will see now. What is the NCCN guideline? ASH guidelines say. So ASH guideline divided into, again, 4 category. As I mentioned, if platelet count is more than 30, observation, which I did in this patient 1 year ago, sent back to home. If platelet count is 30,000, I will start with the steroid with the 6 weeks of the duration. It's not months, 6 weeks. And if platelet count is less than 20, you can admit the patient depending on the whole scenario. If more than 20, you can send the patient as an outpatient. So as I mentioned, this platelet count is 15,000 and multiple site bleeding, I admit the patient. So this is same ASH guideline. So what initial treatment? You can use either prednisolone or dexamethasone. It's up to you. Both things are fine, but dexamethasone pulse is faster and higher initial complete response. Otherwise, both have the same efficacy. However, in this patient, it was used 6 weeks of the steroid, then tapering. But the thing is, again, the patient had the disease came back. Here you can say it went down up to, again, 10 to 15,000. Now the question is, what is this? This is, we label this patient as relapse or refractory disease. I would label this patient as relapse ITP. Why? Because it has initial response, and again he relapsed. He relapsed, so that's why I label this patient as relapse disease. Now, question is next. As David Cottrell mentioned, the important thing is what is the treatment, subsequent treatment. Now, what are subsequent treatment? We have 1 surgical option and 2 medical option, rituximab and TPO agonist. So what should we do? If you go again through the ASH guideline or previous guideline, they mention all 4 categories you can use based on the evidence. But which one? It is very difficult to choose. Recently, they have done very nicely. As Dr. Couture mentioned, 3 to 12 months is the initial and persistent ITP, and here is the chronic ITP. So we are here in this category of this patient. So what you have to do, you have to discuss with the patient. Patient places high value on achieving durable response, give TPO. Patients have high value on the avoiding long-term medication, you can give rituximab. So now this patient actually choose eltrombopag, but unfortunately he couldn't respond. Maybe he was not taking drug properly. With eating something, it's very difficult on ACYs. 2 hours before, 2 hours after. So it was difficult for him to maintain the platelet count, and he continued use rescue medicine of steroid for a longer period, 2 weeks, sometimes 4 weeks. So now what is the next thing, what we should do? He was actually frustrated. The option is now either take out spleen or rituximab, or what is the other options? So now we, more than 1 year of the diagnosis, we label this patient as a chronic ITP. So after discussing the patient, that patient places high value on avoiding long-term medication. As I mentioned, now patient become frustrated by using continuous therapy. So he want either rituximab or splenectomy. So what we should do, as is mentioned, rituximab is what? Just blast the B cell, get rid of antibodies, and ITP will give some remission up to 20 to 30%. So we thought better to use it now before splenectomy to take out the organ. It was done, but again, it was good response, but again, the response went down. So what is the next option? Now, again, the next option, we have to take out organ. Or as David Couture mentioned, there are a lot of other options. You can use MMF, you can use danazol, azathioprine, and some drugs which are still not available, fostamatinib and vincristine. So many medications are there. So what we should do in this patient now? After long discussion, so again, going to the ASH guideline. So the patient wants durable response. Now we have 2 durable response. At this time available, you take out the organ, or you can use another TPO agonist. So and here is the splenectomy you have seen by Dr. David Kuter is that we are not optimized, I mean, splenectomy is rarely needed. It's going down because of a lot of options are available. So it was, and there because of a lot of options, which was mentioned by him also, fosapretinib and danazole, some immunosuppressant medication, and some combination of therapy. So anyway, in this patient, we used romiplostim, and after romiplostim, he maintained actually platelets count very nicely over the 2.5 years actually. Now the thing is, what we should do, as Dr. David Kuter mentioned, like, in our part of the world, we should stop therapy as well. So what is the good idea? What is the next option? Can we stop therapy in this patient? So again, the burning question is, which TPO agonist is the rapid responder, long-term efficacy, and which TPO is having the durability and discontinuation data? All the TPO, as Dr. Kuter mentioned, that they have almost same efficacies. Somehow, romiplostim has shown the treatment-free response. They have more data, about 50%. So in this patient, what we should do, there are 3 options I discussed with him. We can gradually taper off. Instead of 1 weekly, we can make it 2 week, like romiplostim, or discontinue immediately, or don't taper off. So there are 3 options I discussed with him. He agreed to stop therapy after 1 month, 2 weekly, then off. So he off therapy. Now he's off therapy over the 2.5 year more. He was doing great. So he had remission after romiplostim. Now, this is sustained response of this medication. Now, year came 2020 when we were facing viral infection. Then, he came to me, what should I do at the end of the 2020? Should I take a vaccine or not vaccine? I said, yes, you should take vaccine. There is no problem. If anything problem happen, we are with you. So, because based on this data, you can see some people are scared that may cause thrombocytopenia, but data indicates there is no problem because 11 per million doses of thrombocytopenia even happen with the flu and MMR vaccine. So similar, and in other vaccine like hepatitis B, also 10 to 30 cases per million doses as well. So it is similar to this one. So we use this patient. So he used vaccine, but unfortunately, after 2 weeks, platelets dropped. So now what we should do, the next option. So now we have all these things. We can start with the steroid, IVIG, or again, TPO agonist or rituximab. Rituximab is out of the question. Only option is TPO agonist. He has already used it. So I use same romiplostim, and within 2 weeks, you can say his platelets jumped up. So he responded very nicely. And again, he used romiplostim about 3.5 months. Then we taper off first weekly, then 2 weekly, then we stop therapy. Now, story finished about this patient. And then he was well 3 months. So this is the bonus question about this patient. What do you think? I hit the disease or I hurt the patient because of going through this? And I think I hit the disease by giving the proper sequence and proper stoppage. There is still one $6 million question about this patient. Very interesting. This is very practical. Now, this patient has left our part of the world, and he's living more than about 9 months in Europe. And he called me back with his communication with the physician as well. Should I take re-vaccine or not vaccine? This is the question. So I read a paper from the David Kuter that he encouraged the patient, yes, you can take vaccine because the risk is lower as compared to the benefits. So I told him, take vaccine, no problem. Then what happened? Platelets dropped to 1,000. It dropped. Now again suffering. His physician called me again. What you used him before? So I used him romiplostim. He again restarted romiplostim. Again within 2 weeks the platelets went up. Now over the 2 months he is maintaining the platelets count. So by this end of the our local experience, you have seen what I emphasize. I emphasize how we use the guideline to make a key to diagnosis of ITP, how we initiate and what is the goal of ITP treatment, how we use subsequent management, CPART sequence, and what is the win-win of romiplastin and correlation of the vaccine with the ITP. And this is my final. So thank you very much. If any question, I will be happy to answer this. Thank you very much.